What's up, y'all? Y'all are listening to Living Corporate's flagship podcast. If you didn't know, Living Corporate helps organizations build employee engagement and market trust through data analytics and data transformation, our e-learning platform, and brand marketing storytelling. We're so excited for you to be here today. The conversation you're about to hear is going to connect the dots between employee experience and go-to-market effectiveness. If you're not ready, get ready. Here we go. Smith, oh my goodness. We've rescheduled this so many times. It has been such a journey. We've had power outages and hurricanes and COVID, all kinds of stuff going on. And that's not me disclosing your medical stuff. That's me. You know what I'm saying? Like I had some challenges. I'm just so glad to be sitting down with you at Living Corporate. How are you doing?
I'm all right. I am excited about this too. Like I've been waiting on it. The reschedules, it happens, but like I always felt like we would just come back around to it. So it's been really cool to just listen to other pods and just I'm blessed to be here.
And I know that recently you were on paternity leave coming back from that. Congratulations on your expanded family.
Thank you so much. Wow, that's been incredible. Probably the best challenge yet. And she's almost 4 months. She gives me a run for my money every single day, but no, wife and baby are good. So the expanded family is doing well.
It's a blessing. Listen, I want to get right to it, right? First off, you're an Obama leader, 2023 Obama leader. Like, what does that mean? What is that?
So that was a program that I found out about almost like happenstance. President Obama was on The Daily Show with Trevor Noah at the time, talking about some things that sounded cool. And then at the end, launched this program that he talked about, Leaders USA. Apply from wherever. We're looking for people that are change makers. We're looking for people that are in their communities doing the work. And during the interview, he talked a little bit about campaigning in a little bit more West Central and Southern Illinois, where I'm from. And so it really just kind of spoke to me of like he understands the landscape of kind of like where I work, challenges that I might face, and jumped into that program and got picked. So they picked 100 of us for 6 months. We met every Friday, really just kind of going through values-based leadership, what he and Mrs. Obama kind of lead by, and how we can bring a lot of that back to our communities, still doing the work. I think a lot of folks thought it was going to be much more political, of course. But it was really about, no, keep doing the work that you're doing in your communities. How can we enhance that? How can we support that? And was really just one of the most incredible experiences of my life, for sure. Still processing that one, like still not all the way.
That's it. Yeah, no, that's incredible. And then also shout out to Illinois. My people are actually from Rock Island. I don't know if you're familiar with that area around the Quad Cities. But anyway.
Oh, play basketball.
Oh, word?
Absolutely. Absolutely.
You be hooping for real, Macy?
Yeah. Okay, no, look, no. It's high school. High school. Hooped in high school, had a lot of fun. But since we are, Quincy is very interesting. So 40,000 people means we have a big high school. So we're like 4A, but nobody around us is 4A. So we would have to travel to the Quad Cities, Moline, Rock Island Alleman, and Rock Island Rocks. So we would have long bus rides sometimes.
Oh my gosh.
And Rock Island was always, y'all were.
Man, that's so crazy.
A challenge.
I'm gonna tell you something. I'm telling you, like I got my uncles, aunts, cousins, my dad. They all graduated from Rocky, so that's dope. Such a small world. It's so that's really dope. Now listen, I know that you're a behavioral health therapist. Like, just to set the groundwork, what is a behavioral health therapist, and how is it different from other types of therapy?
So in my landscape, I am part of a physician-owned medical group. So we work really closely with all of our specialties, our family practice. And so I think it's just like a broader take on the word therapist. A lot of the things we do are very similar to any counselor or therapist, one-on-one, group, family, that kind of thing. But because we are so embedded with the medical group, we have just a lot of access. We can walk across the way and talk to a nurse, or get a doctor on the phone sometimes, and really be able to have that patient-centered approach. So I think that's just our organization's take on, like, you're not just a therapist. This is behavioral health. Like, this is the well-being of the whole client, or the whole patient, and that's really important.
You know, I would say that from what you're describing, it sounds as if a behavioral health therapist is really thinking holistically and almost systemically, right? It's not just kind of like honing in on one particular element.
Definitely, definitely. It's something that, as far as the systems go, we see that so much, and it can be the education system, it can be healthcare, it can be social services and community. But it's really one of those things that if you're not looking at all of those things, you will miss things with the patient. Like, you will miss really important cues or what's going on with their lives, because of the reactions to those systems and how they are navigating those. So a lot of times, as social workers and counselors, we are helping them navigate those systems within our healthcare space.
Now, I also recognize, and we connected. Actually, you sent me like a genuinely kind message. I was like, yo, that was so nice. About just the work that you appreciate Living Corporate is doing, specifically or particularly through our podcast. And so, I just want to say thank you for the love and the encouragement there. And then, as I interrogated, just looked at your profile, I realized that you exist in this space of health equity, right? So you're a behavioral health therapist, formally trained, and licensed in that context. But then you also exist at this intersection of equity. Talk to me about like what that really entails, like to do this work with that additional lens applied.
So when we're talking about like health equity, I often hear folks talking about bridging the gap and catching people up, but that still sometimes for me is roped up into like catching people up to the majority of where their health space is. And for me, health equity is, no, we're going to give everybody an opportunity and that chance to be as healthy as they want to be, as healthy as they can. And that means every single person gets something different. And so health equity is really looking at, know, what do you need to be healthy, and how can we partner in that? How can our organization partner in that? How can our community partner in that? Because, Adams County at one point was like one of the most overweight counties in Illinois some years ago. And even within childhood obesity, it's like, what are we doing? Like that's a health equity issue. It's gotten a lot more, obviously, notoriety post 2020 for a lot of different reasons, but like it's been around for a while, and we all need to really be paying attention to how we can integrate health equity into everything we do, whether it's school, work, home. Like, health equity is that important.
I would think though, and I would think that like health equity, like conceptually, it's really just a part of about just effective care, right? Like how can one deliver effective care and not by the way that you're, and by your definition, not be equitable, right? Like using your language, right? Like, and then I also, like, I'm not ignorant to like the history of healthcare in America, right? In terms of the fact that like Black women are often used as pin cushions and all sorts of horrendous things done to them in the name of health science, because there was this underlying belief that they did not receive or experience pain in the same ways that white women did and do. Right. And I also am not ignorant to the fact that those beliefs are pervasive through today. Right. Now, let me ask this question. Right. So you're existing again, like you work in this space. You're a senior advisor, like as a behavioral health therapist, but again, also like also like advising on matters of diversity, equity, inclusion. What does that look like in today's environment where like DEI, like that language has now been like, I'm going to call it like slurified, right? Like you can't even, like it's been completely hijacked to mean all manner of things. What has that been like for you navigating that space while you're trying to do the work that you're doing?
I mean, at first, I knew that this was going to be a very interesting ride, and I didn't know what the outcome was going to be, because I think for a lot of us as Black professionals, we had seen stuff like this before. Like, we'd seen names trending in the country react, but then go back to business as usual. I think when things started not to go back to business as usual, it signaled to a lot of people, okay, let's get as much work done as possible in whatever this time frame is going to be, because what we do know is that there's always going to be some sort of backlash, or we're going to we're going to resign. We're not going to want to do things this up close and personal for however long. And so it was really important for me to start building those relationships with people at the top. So whether that was people, we call it people in culture, HR, whether that was the CEO, it was, let's build these relationships. Let's build some trust. Empathy was there. I think that was something that a lot of people led with at first. And I think you can catch people with that. I don't know that it will last with individuals though. So you really kind of need more than that when we're doing in the DEI space and the health equity space. Like, how is this impacting the patients? Like when you were talking about delivering care earlier, if we're not delivering culturally humble care and we don't have culturally humble providers, then we're not doing health equity, because you have to understand, or at least be empathetic to someone's lived experience in order to get them the care that they need. And you can't do that without building the relationships between patients and providers. So really, I saw myself as a model for what we need throughout the entire organization. And if I can model some of this behavior, if we can then model it to everybody else, let's see what happens with that. And we caught some really good traction around the health equity space. Now, DEI, there was a lot of misinformation out there. So we had to work diligently on, what are we telling people? What is the messaging? And do we want to add a B? Do we want to add a J? Is it Jedi? And I was like, look, that's fine. That's fine if however you want to define it. Do people want to work here? Do they feel included? And do our patients feel like they can tell their doctors everything about their lives? I work with a lot of LGBTQ folks, queer, non-binary, trans folks, and they are telling me sometimes more than they're telling their physicians. We can't have that. I can't always communicate those things with your physicians. They have to hear it from you. So that was really a lot of things that we were working on. How do we connect the dots with people feeling more comfortable with our providers, with our physicians, nurses, whomever, from start to finish within the organization? And sure, that's DEI. I didn't always call it that. Not always. I just wanted to have the conversation. And so sometimes that was easier without saying, here's a presentation on DEI. It's like, here's a way to communicate with patients better. Also, seen as inclusive.
Right. And I think so. And that's where I've been there for a while. I do think that, like, this is a conversation a little bit beyond healthcare, but, all of the DEI stuff at a certain point gets a bit exhausting, because there's this desire. And I do think that we're in this era of, like, just society where we want to label everything. Right. And so, like,
Right.
As an example, wow, like, I'm about to go this way, but I promise it's connected, Macy. So talking to my cousin, I'm talking to one of my family members, and we were talking about, like, queer identity and, like, like everything being on the spectrum, and like this argument of, and, like, we had a discussion about, like, like, look, like, people have lived in these various ways, like different various identities or parts of the spectrum. And, like, since time immemorial, they just didn't call it. It wasn't always just called something. It was just like, hey, we're just living. Right. I think, and I'm not, and this is not me being against calling something a thing or self-identifying as something. I do in theory appreciate the idea of, like, hey, I just like this, or this is just how I am. Like you don't worry about trying to tell me what I am. And I don't necessarily feel the need to declare to you what I am. I'm just kind of, it's just how I am. Right. Now, again, I say that though, as a straight Black man participating in the patriarchy. I get that. So, like, I'm not poo-pooing anything. Mm-hmm. I am saying though that, like, we are, and it's not, I mean, that's even critiquing this era that we're in. It's just that there were people in the past who lived in all manner of ways privately, and they just weren't terms for it, right? It was just living. And I think the DEI stuff gets a bit exhausting because we're constantly trying to, like, put a bunch of language and terms to things, when in reality it's just what you just said. Hey, this is just how you can engage your patients better. Hey, like, this will just help you. Like, your goal is to deliver quality care. This is going to help you deliver quality care. Mm-hmm. Like, we don't have to call it anything. Like it can just be how you need to be to deliver care. Right.
Absolutely.
Now, as I think about, the time in which we're having this interview, closer to the fall, in the middle of a major election, there have been ongoing decisions, right, made by legislative bodies over the past several years that are impacting the health of all people, certainly those on the margins. As you look at the landscape of decisions being made today, as well as decisions that seem to be coming down the pipeline, do you have any concerns? Do you have any trepidations or anxieties at all?
I mean, for the healthcare space and DEI and health equity, I think it's going to be really difficult to get out of delivering the best possible care in whatever way that looks like. Only because, like, if people remember, in the midst of a pandemic, in the midst of we had just started to get vaccinations, I believe. The CDC came out and said, "Hey, in addition to the pandemic being like really awful, we have some other awful news, and that's that Black and brown folks are dying at XYZ rates." And so, once the CDC comes out and says that, how do you backtrack from that? We have now said the quiet part out loud, which academics and other folks have been saying for decades, but here comes a stance. And then I'll never forget, there was a graphic of the social determinants of health, which is just like 6 ways of our well-being being categorized, like education, community, some other things. And post George Floyd, Breonna Taylor, and Ahmaud Arbery, all of a sudden there was a thin line that went through it that said racism and discrimination. And I said, "Oh, you changed the graphic. Like that's something different. That's going to go in the textbooks. That's going to change the way that we teach." I said, "Oh, okay. So I'm going to have to think about this a little differently." Whereas some folks were scrambling to get as much done as possible, I'm like, this might be around to stay within the healthcare space. Other spaces like education, we see critical race theory and whatever else getting tossed out left and right. I don't know as much about those spaces, but for the healthcare space, I think regardless of what happens on that national scale with what's going on in these elections, how do you backtrack from racism is now a public health crisis?
Yeah.
Like, that's what y'all said. So that's what we're dealing with. That's what we're navigating.
Yeah, it's interesting as I think about just like, as I think about the few spaces that seem to be a bit more bolstered or where there's going to be leeway, I do think about healthcare because it's healthcare. Like, people are dying, like in like up close and personal.
Right.
And so, I remember like, in my during my time as a consultant, and this was years ago. This was like back in like 2020, 2019. A little bit before, these conversations about health equity were coming up, but health equity was always it's interesting how you're framing it, because health equity is, I've seen it often framed a bit separate from the broader DEI conversations, because there's this agreed upon understanding that, hey, we're talking about patients and like delivering care to patients, and a bit of an unpacking of, okay, hey, everybody that comes in here, we're responsible for them in some manner or form. I'm curious, in the work that you're in today, right? What do you catch yourself advising and guiding your leaders on most?
That is such a good question, because it has changed, I want to say sometimes from month to month, from week to week. But recently it's been around, okay, we've done all these things, and we've gotten some cool grants, and we've received some recognition. And so it's almost like not a now what, but how do you think bigger, again, against the backdrop of we are however many hours from Cook County, we are very isolated in where our resources can be pooled. So it is that what's next and how to be more intentional. How can we be more intentional with our employees? And that also requires what? Looking at benefits. So how can we be more intentional with our patients coming in? Well, that requires looking at data. Are we gathering the data? Like, who is here? Who is working for us? And so it led from those conversations to now looking at this data, looking at what's gone well, And what do we need to change? What are people saying? So, people do surveys and we do those as well. But I believe in a more like, do we have a continuous feedback loop? Are leaders talking to people all the time, or just for their, what do they call, like, quarterly appointments or meetings? Or like, are we just talking to people four
Yeah.
times a year, or is it going to be more ongoing? Like, to me, that's that, inclusion, belonging, and you can keep a little bit more of a control, or at least keep your thumb on something to know what's going on if you're having ongoing conversations. So that's been something it's a different model for a lot of organizations because everybody's busy. We've got a lot of providers, we've got a lot of physicians, nurse practitioners, a lot of therapists that, we're doing notes. And if this is important, if health equity, DEI, JEDI, whatever we're going to name things, if it's important and it's a business imperative or whatever folks say, how are we showing that? Because at the end of the day, all of that language just means that, okay, we are going to be doing health equity. What does that mean for each organization? What does that mean for each healthcare space that wants to participate in these things? So it's really been a lot more advising around, are they talking to people? Have they been to some of the staff meetings? Do they know their direct reports' names all the way? I mean, we're a larger organization, so you can't get in with everybody, but you can get in with some people. And when they see you, do they feel like they got to tighten up, or can they just talk to you like a human? Can they talk to you like a person? So that's been a really interesting space of some of the leaders just kind of being like, like sometimes I feel like they don't want to talk to me. And I'm like, oh, well, we're all human, but do they feel like you are human? Or do they feel like you are from the ivory
Coming
tower
down.
and everything must be just like
Mm-hmm.
buttoned up, right? So that's been really interesting, seeing people just kind of like, what does it look like for you to be a little bit more unbuttoned and approachable? And then you get to deal with things on more of that
Yeah.
human basis. And I mean, that calls back to my behavioral health training. Probably, I'm biased. I believe in the human
Sure.
connection.
Like, my follow up there is, I would imagine, to define what healthcare equity looks like, practice to practice or institution to institution, one would have to interrogate their data. No. So what role does data analysis play in setting and building a health equity strategy?
I think I led with that a little too early. I've learned so much, Zach. I've learned so much in this role. Because I feel like I was like almost like demanding the data at first and hadn't built the relationships.
Mm,
It was also like, Macy, what do you want with that? Like, what are you going to do with that? And I'm like, aren't y'all curious? Like, don't y'all want to know
yeah.
too? So, once that trust has been built, when we were looking at the data, there were some things that were really making sense, like in terms of attrition, in terms of who was there. Now, again, we are a community that is 90 something percent white, probably closer to 95 than not. And still, our employees should reflect the community. Our organization should reflect the community. And so when we started to look at those things, some things were matching up, some things weren't, but at least we had eyes on it. Because if you don't have a baseline, how do you know what you're doing? How do you know what's going to work, or what hasn't been working? So for anybody, the data is going to be so important, because how are you going to tell your story or your narrative to anyone? How are you going to prove that what you've been doing has been effective? Because again, the heart stuff, the empathy, it was there. It has a role. It definitely has a role, but we really need the data to put that entire picture together of, what did you start out with? What did you end with? And how are you planning for the future to do better? So for us, I feel like our organization is constantly looking at data in different ways. Because I remember, I'll never forget, I read an article about that Black women, those assigned female at birth, having like the worst cardiology rates in rural areas. And I was like, oh, okay. And like in my family, we have like some heart stuff that runs. And I was like, so if I'm just taking that at face value, it's like walking into any organization, healthcare space in this community, and being assigned female at birth and having these cardiology things that are running in the family. Am I setting myself up? Do I just need to go to St. Louis or Chicago? Or can we look at the data and see what's really going on? So it was those types of things that, like, well, yes, there is reading involved, and that helped move some things along too, as far as data, because then it made sense why we were looking at that data. It's like you do have to do a little bit of reading. You do have to do a little bit of self-directed stuff on your own, so that it's not just me talking at folks, and so that's not just or the DEI person or whatever
Yeah.
that looks like.
Yeah, the data part is tough, right? Like, because I think there's so many sensitivities around sharing that information, and yet that's where like the stories really live. And of course, the stories live in connecting and talking to the people. That human experience. Fully receive what you're saying there. When you talk about looking at the macro, right? You need that data so that you can create that analysis. And it's interesting to your point about like just research and studies. It's in, years ago during our Pfizer one of our campaigns with Pfizer, we had on a woman who was primarily focused on black women mortality rates and just and equitable care, right? And she told me a stat that was so crazy. I've been telling people, I was like, I'll never forget this. She said that black women mortality rate goes up the more educated the black women are. So,
absolutely,
right?
Absolutely.
That was so crazy to me. I said, how is that possible? That the more educated, right? Like, so black women PhDs have they have a significantly higher mortality rate than black women who didn't graduate high school. And it's just like, how? And so anyway, I believe the future of any space that's revolving around an equitable experience, fair experience, even just any space, anything that's revolving around driving best results, irrespective of the industry, healthcare, tech, whatever, finance, whatever, it's going to need to be driven and starting with the data. I love the fact, though, that you point out the very real human element of it is, as a business partner, you can't always go in and just say, hey, give me all your data, right? And even if you were to work with like senior leadership and they come in and say, hey, give Macy your data, well, that may not build the best relationship over time. And so having an understanding, stories and people and all those things is critical for that. So that makes a lot of sense to me.
Absolutely. And around Black maternal health and infant mortality, I'm not going to talk about it all day. I'm not, because I know better, but very much believe that like my family and I am a product of that. I have asthma. If you look further in the studies, they start studying the kids that are born from those Black women. And my mother was an executive here in town in a mostly white space. And so when we're talking about minority stress and weathering and things that Black and brown folks are experiencing in where they are the minority, leading to some of these issues. I was born I think almost 6 weeks premature or something like that. And that did not even get the stats until my very first day of grad school for my master's at SLU. We watched a documentary from the 90s, from the early 90s, on Black maternal health and infant mortality. And so in understanding that, I literally called my mom, like, Mom, so we never talked about this. We never talked about how that could be connected and how we could be part of this bigger scheme of things. But there came an opportunity for the organization that I work for to do a birth center, right? And I'm a nerd, so once they posted the paperwork to the state, because there's this whole process that they have to do, I went and read through it, and they were talking about, what was it? Low risk pregnancies, that's who the birth center was for. And I was like, ding, 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 here's my senior advisor hat. How are Black and brown folks going to use that? Black and brown birthing people who already have this higher risk, I want them to be able to use it. And it led to this incredible discussion of that's a different lens. If we're going to do that, we need to talk about it more. So we're going to have to set some more meetings. We're going to have to talk to some more experts, because I consider myself an expert in training, a budding expert in training. So let's bring some folks in that really know this stuff and get into the nitty gritty. And they were able to do some things that now it's an incredible project. And so that's just another small story of when you have, the empathy, the storytelling, but the data, it shifts almost everything instantly.
Macy, I feel like we could keep going. I want to give you space, because I also want to give space for a part 2. But before we let you go, let me ask you this. Again, I think I'm a bit of a realist, probably to the point where I struggle with optimism, right? I do feel though, in the role that you you play and that you lead and the space which you inhabit, you have to have some degree of hope. So if you were to give me like the top 3 things you're the most hopeful for right now as a behavioral health therapist who exists at this intersection of lived experience, advocating for equitable care for everybody, especially those on the margins, what would those 3 things be?
I think for me, especially in my work as a therapist, what keeps me whole are the youth that come to see me. While they don't always have the context or the words like we as adults, or they call me an adult, I'm a millennial, but I'm old now. So they will talk about what they want to do and how they can't wait to get more involved in civic duties because there are issues that are really important to them. And I do not remember being as politically activated as them. And I lived through the first Black president and whatnot. And I have that lived experience of watching that election, and they are so charged and ready. It's like they just want us to tap them in. And it's like, well, can you graduate high school first? But they are really, really just seeped into things that are not TikTok. So, I feel like Gen Z and those behind them kind of get this rep for being very impulsive and not knowing enough and maybe not wanting to work and all these other things. And I'm like, have we looked around the country? I don't know how many of us really want to do a whole lot. They are just very honest about it. And in their honesty with me in sessions, in their honesty when I see them in the community leading advocacy work, that gives me hope beyond measure. I think the second thing is what we just got done talking about is the data, because the data will always be there. It's really difficult to argue with the numbers that are right there. Like when we're talking about Black maternal health and infant mortality, when we're talking about minority stress with LGBTQ folks, it's there. These are the responses that people gave on the survey, or, there was this qualitative study or this quant study, and this is what happened. It is very difficult to argue with things that are right there and they are factual. Less feelings involved, right? Like less empathy, but folks using the data and having that data there ready for utilization gives me hope. And then I think the third thing will always be that community of belonging. For me, for others, being able to find your people, it has been what has given me hope, because it makes me feel less like I'm being like gaslit by the entire country, and that there is sanity there, and that we are all experiencing these things in this conundrum of whatever we're going through, and we're not necessarily alone, even though like it can feel very isolating where I am. But whether it's like the Leaders USA folks through the Obama cohort, or my doctoral program, or things like that, like I know now that I have peers that I can lean on. And so I lean on that and encourage others to find their peers, find their cohort, or I think folks are calling it now like your own personal board of directors. And I'm like, well, that's interesting. I've never thought of it like that. But, find whatever those things are, whoever those people are for you, and leaning into them so that you can, if you don't have hope, start to build it. But certainly those are the 3 things that keep me up and at work every day.
Macy Ferguson-Smith, I appreciate you. Thank you for being on Living Corporate. I look forward to having you back soon. Let's catch up soon.
Absolutely. Thank you so much, Zach. Dream come true. Been listening to y'all forever. Send these podcasts far and wide. You have no idea. Even within my own organization, which, may have been a stretch again in the beginning. I've learned a lot.
We'll talk soon. Peace.
Absolutely. Thank you so much. Bye, Zach.
Awesome.
Living Corporate is a podcast by Living Corporate LLC. Our logo was designed by David Dawkins. Our theme music was produced by Ken Brown. Additional music production by Antoine Franklin for Musical Elevation. Post-production is handled by Jeremy Jackson. Got a topic suggestion? Email us at livingcorporatepodcast@gmail.com. You can find us online on Twitter, Facebook, Instagram, and living-corporate.com. Thanks for listening. Stay tuned.